Hello, my name is Tammy Bailey-Stanton. I'm a specialist emergency physician at Rahima Musa Mother and Child Hospital, and I work in the emergency department there. I'm also a lecturer at the University of the Witwatersrand, and I lecture in the Division of Emergency Medicine. I might have met some of you guys when you've visited us in the emergency department at Rahima or Helen Joseph, or at any of your pre-hospital rotations. Today I'm going to be talking to you about pediatric resuscitation. The first part in any resuscitation is for the rescuer to ascertain if there's any hazards and to ensure that it is safe to approach the patient. This implies looking for any environmental or biological hazard and taking adequate precautionary measures. For general patient interactions, we need to adhere to the minimum standard precautions. This means wearing a water-resistant surgical face mask and gloves. Most healthcare providers feel completely out of their depth when faced with small children or infants. A pediatric resuscitation may be incredibly daunting. So what are some of the main differences in CPR for kids? There are just a few major differences when we're looking at resuscitation for kids and resuscitation for adults, and I'm going to focus on a few of the more important differences. When we look at compressions for adults versus compressions for kids, there is a difference. If we are a team, so we've got 2 providers or more, we'll look at a compression to ventilation ratio of 15:2. However, if we're a single provider, we'll still go with a compression to ventilation ratio of 30:2. Ventilation rates for kids are different from ventilation rates in adults. Whether it's rescue ventilations or ventilations during continuous CPR with an advanced airway in place, we'll look at a ventilatory rate of 1 breath every 2 to 3 seconds, which is 20 to 30 ventilations per minute. The dosing of medication is also different for kids. For example, the dose of adrenaline for an adult, any adult in a resuscitation, is 1 milligram, regardless of their weight. But in a kid, we'll use a dose of 0.01 milligram per kg of adrenaline. And this points to us making sure that we're using the correct doses for kids, because medication doses for kids is based on weight. The energy dose for defibrillation is also different for kids. If you've got an AED, you'll use an AED with a pediatric dose attenuator. If not, then you'll use the adult pads. If we've got a manual defibrillator, we'll use a dose of 2 to 4 joules per kg. So what about hands-only or compression-only CPR? If it's not safe for you to provide mouth-to-mouth resuscitation or with a barrier mask device, bystanders then definitely should at least provide continuous chest compressions. For infants and children with a pulse but absent or inadequate respiratory effort, we need to give 1 breath every 2 to 3 seconds, which means 20 to 30 breaths per minute. One of the major changes in the 2020 ILCOR guidelines is the pediatric ventilation rate with advanced airway during CPR. This recommendation is based on a study that found improved outcomes when the ventilatory rates were higher than the usual 12 to 20 breaths per minute, which used to be previously recommended. So the subsequent recommendation is to do higher ventilatory rates during CPR when there's an advanced airway in children. So the recommendation now is during CPR with an advanced airway, target respiratory rate of 1 breath every 2 to 3 seconds, which is 20 to 30 breaths per minute, accounting for age and the clinical condition of the patient. Rates exceeding this range may compromise hemodynamics and cerebral perfusion. The 2021 ILCOR guidelines reiterate the importance of high-quality CPR. Advanced life support interventions are pointless if basic life support interventions are inadequate. High-quality compressions are vital to excellent BLS. There are 5 components of high-quality compressions. The rate of compressions for infants and children is 100 to 120 compressions per minute. The depth of compressions is 4 to 5 centimeters, 4 centimeters in infants and 5 centimeters in children. Release is important. Allowing for full chest recoil is important for adequate ventricular filling and coronary perfusion. Compression should ideally be uninterrupted. Minimizing interruptions in compressions should at least be the aim during CPR. The use of feedback methods to improve the quality of CPR is also encouraged. While feedback devices may improve the quality of CPR, they cannot be compulsory because their expense might limit their availability. While you might not have a fancy feedback device or an A-line for the patient, pretty much all healthcare providers have access to smartphones. The cheapest tool to improve the quality of our CPR is to probably download a free metronome app. There are other apps, obviously, that I'm sure lots of you are aware of, for real-time monitoring of CPR. But a free metronome app is probably one of the easiest ways to make sure that we're doing adequate compressions at the correct rate. This slide shows the AHA BLS algorithm for children. The one on the left is for a single rescuer, and the one on the right is for 2 or more rescuers. The next video demonstrates the components of CPR in a child.
Today we're going to review BLS for the healthcare provider for the pediatric patient, for the child. Let's take a look at those skill steps now. First, establish unresponsiveness. Next, look for breathing for about 5 seconds. If this child is not breathing, immediately call a code, get some help coming. Now, in healthcare provider, 2 rescuer BLS for the child, our compression to ventilation ratio is 15 to 2. You're going to provide 15 compressions, then provide 2 ventilations of air. We're still going to attach this child to an AED to see maybe if they are in a shockable rhythm. Let's take a look and see what those skills look like, shall we? Hey kid, you okay? This kid's unresponsive. He's not breathing. Nurse, call a code. Hey, this kid doesn't have a pulse. Hey, get over here with that AED. I'm starting compressions. And go right to 15 to 2.
Place electrodes.
The AED's here.
Place electrodes.
Pads on him.
Place electrodes. Do not touch patient. Analyzing rhythm. Do not touch patient. Analyzing rhythm.
This is the South African BLS cardiac arrest algorithm. That is much easier. It combines the BLS algorithm for CPR for adults and for children. And it also includes the ventilatory rates for a pediatric patient with a single rescuer or 2-person rescue team. I personally prefer this BLS algorithm to the AHA ones because it's much less complicated, and obviously then we don't have to have a whole bunch of different algorithms. It's all in one. The next video is to demonstrate the components of CPR in an infant.
welcome to today's video on healthcare provider BLS for the infant. Let's take a look at what those steps look like, shall we?
Hey, Doc, catch.
Who throws a baby? Step 1, establish unresponsiveness. 2, assess for breathing. If this infant is not breathing, call a code immediately, get some help coming. Hello, cutie. And you're unresponsive. And you're not breathing. Nurse, call a code, I need some help in here. Next, check for a pulse. Check for no more than 10 seconds. If this infant does not have a pulse, immediately begin chest compressions. Check for a pulse. I got no pulse. Great. That's fantastic. My kingdom for 2 nurses right now. There goes my kingdom. I need you guys to take over CPR on this little one. You ready?
Yes.
Now in 2 rescuer CPR for the infant, the way we perform compressions is with a circumferential grip. Our thumb's on the sternum between the nipple line, and we're going to compress about 1/3 the distance anterior posterior of this kid's chest. So almost halfway through this kid's chest you're pushing. Again at a rate over 100, and a compression to ventilation ratio of 15:2. Okay, remember, we're going to do our compressions 15:2, 15 compressions, 2 breaths of air. Watch for that chest rise.
This is a slide of the American Heart Association PELS algorithm. This algorithm emphasizes the importance of hunting for reversible causes, all of the H's and T's. Probably the most important H's and T's in infants and children is hypoxia and hypovolemia. Depending on the setting, toxins also very well might be relevant. The antidysrhythmic medication of choice for pediatric patients is either amiodarone or lignocaine. The dose of amiodarone is 5 milligrams per kg and can be repeated up to a total of 3 doses. Intravenous lignocaine may be used as an alternative to amiodarone with a loading dose of 1 milligram per kg. This algorithm emphasizes that medications can be administered via the intravenous or intraosseous route, as they are equally acceptable. The initial dose of adrenaline must be given as soon as possible for children with out-of-hospital cardiac arrest and non-shockable rhythms. The pediatric cardiac arrest algorithm emphasizes the early administration of adrenaline for asystole and PEA. By the cute little graphic of the adrenaline syringe in the algorithm as a cute memory aid. The most recent guidelines discuss in more detail the use of cuffed endotracheal tubes. So cuffed endotracheal tubes can be used over uncuffed ET tubes for intubating infants and children. But it's important that when you're putting in a cuffed ET tube, that you've got to take note of the size of the ET tube and the position. And it's really important to monitor cuff inflation pressures, which we need to keep usually between 20 to 25 centimeters of water. Although this is not a new recommendation, it has been included in the recent guidelines that cricoid pressure during intubation is not recommended routinely for endotracheal intubation of pediatric patients. Knowing your rhythms and rhythm recognition is vital during cardiac arrest. We need to be able to identify which rhythms are shockable and which are non-shockable. But it's probably really important to know that in pediatrics, most of the rhythms that we'll see are PEA and asystole. The patient might, at some stage during the cardiac arrest, develop a shockable rhythm. So for this reason, it's really important, even in infants, to drag out the defibrillator and the monitor and make sure that we're actually monitoring rhythms. Because if we're not looking for those shockable rhythms, we're never going to get to the stage where we can defibrillate the shockable rhythms. The 2020 guidelines recommend the use of AEDs in children, and if an AED is available, also to use it for infants. If we have got about a manual defibrillator. It is preferable to use a manual defibrillator because then we can target the dose, the energy dose, for the child in front of us, so 2 to 4 joules per kg for defibrillation. So preferentially, we'd rather use a manual defibrillator because we can select the energy. The next best option would be to use an AED with a pediatric dose attenuator. And the last option would be to use an AED with adult pads. The next most important thing is to find the reversible cause. Be systematic in hunting for your H's and T's. It's the best way to ensure a ROSC in our reversible cardiac arrests. Many textbooks tell us that children are not just little adults. We are taught how children are so very different from adults. We learn about their physiology and their anatomy and how it differs from adults. And this is particularly resonant for neonates. And in my opinion, neonates are much more like little aliens than humans. But jokes aside, despite this, I believe that there are way more similarities than differences when looking at kids and looking at adults. A baby elephant, after all, is more similar to an adult elephant than anything else in the animal kingdom. A baby elephant is just a small elephant. There's no need to be intimidated when faced with children, because after all, kids are just small people.